Hello, good morning, good afternoon, and good evening to all of us speaking and wonderful audiences in different parts of the world. Welcome back to yet another episode of very educational lectures for you. The speaker for the first session of today's webinar is our honored guest from China, Professor Li Qiang. Professor Qiang Li is an associate professor and deputy director of Neurovascular Center, Shanghai Hospital. He is a committee member of the Shanghai Neurosurgical Society as well as of the Shanghai Medical Association, Chinese Federation of Interventional Clinical Neurosciences, and his research and clinical interests are focused upon the management of cerebrovascular disease by endovascular techniques. We are extremely honored to have him today at our webinars, and today he'll be talking about curative embolization of AVM strategies and planning. The speaker for the second session of today's webinar is our honored guest, who is a young neurosurgeon from Bosnia and Herzegovina, Dr. Adi Ahmed Spahic. Dr. Adi works as a neurosurgeon at the University Hospital of Sarajevo, Bosnia and Herzegovina. His primary interest is in skull base and cerebrovascular surgery. He is a very determined neurosurgeon and acquired additional neurosurgical knowledge from several countries such as Sweden, Germany, Austria, Slovenia, Bulgaria, Lithuania, Japan, and the United States of America. He is the author and co-author as well as reviewer of a couple of scientific papers and book chapters, the most significant of which are published in prestigious neurosurgical journals. We are extremely honored to have him today at our webinar, and today he'll be talking about vascular cases in Bosnia and Herzegovina, a young neurosurgeon's experience. The chair for the first session of today's webinar is our honored guest from Japan, Professor Shigeru Miyachi. Professor Miyachi is a professor and director of Department of Neurosurgery, Neuroendovascular Therapy Center, Aichi Medical University, Japan. He was the past president of the Asia-Australasia Federation of Interventional Therapeutic Neuroradiology and the Japanese Society of Neuroendovascular Treatment. He is a noted author with several publications in various peer journals. He has received several awards, including the Best Doctor of Japan award in the past. We are extremely grateful to him for accepting our invitation to chair the session of Professor Li Qiang. The chair for the second session of today's webinar is our honored guest from India, Professor Jayanand Sudhir. Dr. Jayanand Sudhir is a known cerebrovascular neurosurgeon who specializes in vascular disease of the brain, including aneurysms, AVMs, Moyamoya disease, and cerebral bypass procedures. He has performed over 100 cerebral bypass surgeries, mainly for Moyamoya disease. He was trained in advanced cerebrovascular surgeries in Hokkaido University Hospital and Teishinkai Hospital, Sapporo, Japan. His research focus is on Moyamoya disease, application of computer fluid dynamics, and cerebrovascular diseases. We are extremely grateful to him for accepting our invitation to chair the session of Dr. Adi Ahmed Spahic. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome all the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online platform to our first chair, Professor Shigeru Miyachi.
Thank you, Raja. And it is very honor for me to chair this first session. The curriculum vitae of the Dr. Lee has been already introduced by Raja. So today's topic is curative embolization of AVMs. That is a very important topic because our endovascular strategy for the AVM is firstly that is a transarterial embolization within liquid materials. But now we have a lot of strategies, and particularly the very new treatment method is a transvenous embolization using Onyx. And I think that is so introduced by Dr. Schapo from Germany. And I think maybe in China, there are a lot of embolization using such various techniques. And I think Professor Lee will talk about the very newest strategy in China. Could you start the lecture, Dr. Lee?
Okay, thank you. The introduction of Dr. Rija and Dr. Mirashi. So let's begin my lecture. Thanks. I'm so honored to be here to give the lecture in this webinar, and I will share some of our understandings and experience in the curative embolization for breath and arteriovenous malformation. As we all know, for the breath and AVMs, it is not very common cerebral vascular disease, but the average age of the diagnosis is very young, and the hemorrhage happened in more than half of the patients, and it is the most common cerebral vascular disease causing neurological deficit or death in youth. So it is very important. And for the ruptured AVMs, it should be treated more aggressively. But for the unruptured AVMs, the treatment strategy is controversial after the publication of the Aruba trial. And this trial is a prospective multi-center parallel design and non-blinded randomized controlled trial. And it is the first RCT in the world to compare with the different modalities for the treatment of unruptured AVM. Unfortunately, it resulted in that it is not a good to treat this patient for their interventional therapy, but it is better to treat the patients with the medical management. So after the publication of this trial, many criticisms has arisen for this trial, and many publications has challenged the result of the Aruba trial. So for the surgery for the low-grade AVMs, we can see here the result for the surgery is better than the result for the medical treatment arm of the Aruba trial. And also for the radio surgery, you can see here in this study, which including over 200 patients and with a long follow-up period, and you can see the stroke and death after the radio surgery is significantly lower than that anticipated in the Aruba trial. But there is also some challenges in the AVM treatment. For the microsurgery, it is very challenging for resect the high risk of the AVMs of the spatial Martin grade 3 to 5. And for the radio surgery, and you will get lung latency about 2 to 3 years, and there is a late hemorrhage during the latency, and there is late complications, and even it is the high risk for the adequate area AVMs and very lower eradicate rate for the adequate area AVMs. But how about the endovascular therapy? Actually, the endovascular therapy is the previous role of the endovascular therapy is for the adjacent treatment for the radio surgery or for the microsurgery. And if you see the literature which has been published before, you will get that the very low rate of total obliteration for the endovascular therapy. And for these publications in the 1995, there is only 4% or 5% of the total obliteration of the AVM was get. And even for this study with review, which has been published in 2015, there is only that is only 24% of the totally obliteration for the AVM, and in the majority of the patients, the they only resulted in the partial obliteration. For the preoperative embolization is the most popular strategy for the resection of the AVM, especially for the high-grade AVMs. But in this study, which has compared with the preoperative embolization plus surgery, VS surgery, and you can see here there is no significant difference in the baselines, but there is no significant difference in the AVM obliteration. While with a more embolized patient has a decline in their MI scores. And the duration of the surgery, intraoperative bleeding, and duration of the hospitalization and the postoperative symptoms was similar in the both groups. And even for the high-grade AVMs, there is no significant difference between the two groups, or even severe post-operative status in their pre-operative embolized groups. And for the radiosurgery, in this review, you can see here that the preoperative embolization will result to the lower complete eradication of the lesions, and maybe a higher annual hemorrhagic incidence. So even for the high-grade AVMs, such as the grade 4 to grade 5 AVMs, the risk of the hemorrhage is even higher than the natural history. So can we do the curative embolization for the AVM? The answer is yes. And you can see from the publication of the Benavenus and Yesagio in about over 20 years ago, they state that you should set the goal of the endovascular treatment prior to the procedure, and you should determine the strategy, including the assess, the catheter selection, and embolic agents, and you should plan the topography of the cast, and depending the specific angiographic architect or topography of the individual AVMs, and depending on their past history and clinical presentation for their patients, and the predefined goal of their embolization. And they got their highest obliteration rate only with the MBCA of the total obliteration of the 40% in more than 300 cases. And Professor Yu has got even a relative higher obliteration with the MBCA, and in their conclusion, their AVM lidars was not more than 3 centimeters, and the number of the AVM feeders was not more than 3, and the AVM lidars was accessible with the tip of the catheter is the predicting factors for the total obliteration. And in the most recently, Dr. Sakai gets more than 50% of the total obliteration using the prolonged intraleral onyx injection technique. And these publications or studies all showed that the feasibility for the curative embolization. But 10 years has passed, and the techniques about the imaging, materials, and intraoperative monitoring, and even the techniques for the embolization has been improved, and which we can get a much higher totally obliteration rate, and you can see you can see that nowadays we can get a curative embolization for very individual AVMs. These improvements, including in the imaging, just like I showed here, and then you can use the 2D or 3D to fuse the images of the AVMs, and you can see from the fusion images to determine which is part of the AVMs are supplied by which feeding arteries, and how the venous part join together, and to get a successful endovascular therapy, and to make their treatment much safer. And with these fusion techniques, and even with the 4D DSAs, and you can get the compartmentation for the AVM just like this. And you can divide the AVM, the total AVM, into several parts, which parts you can see here with the single or multiple feeders, and they will to drain into different branches of the veins, and where does the veins join together. And with the 4DSA, you can see the images of any time and with any angle, and you can see the feeding arteries from the overlapping. And you can see the AVM related AVMs, and recognize the fistulars. And with the recent imaging improvement techniques, you can see the AVMs just like this one, and it can clearly delineate the microangial architecture of the AVMs, and which can help us to see the structure of the AVM, to understand it. And the most important thing is that we can recognize the structure of the veins, of the drainage veins. And you just here you can see the primary veins, the secondary veins, and where the secondary primary veins join to join together, and which part when you are embolized one part of the AVM through one feeder, and where should you stop after during the infiltration of the embolic material. And with the intraoperative neurological monitoring, and we can safely embolize the adequate area AVMs. The long age, the embolic materials such as the onyx and the fields are a revolution for the embolic materials, which has been used in the embolization of the AVMs. And also the microcatheters. The most important improvement in the microcatheters are the tip detached catheters. With these kind of tip detached catheters, including Sonic and Apollo, and you can permit the neurosurgeon or neurointerventionist to inject the onyx of fields with no rush to retrieve the catheter. And there are also some techniques which has been merged in the embolization for the AVMs, such as the pressure cooker technique, which has been invented by René Chaput in 2015. And he used a tip-detached catheter for embolization of the AVM, and used another catheter to pack the coils and inject to make the plaque, and to avoid the reflex of the onyx. And this is a 16-year-old male patient with a headache for 2 months, and there is a medium-sized AVM in the frontal lobe. And firstly, we chose to select the micro fistula of the AVMs, and to embolize with some glues. This is the first session, and in the second session, and we chose the main feeder of the AVM, and use the pressure cook technique, and there is some onyx was injected into the AVM and resulted in the totally obliteration of the AVM. And you can see here is the cast of the onyx, which is the same as the AVM you see before the embolization. And the 1 month follow-up shows stable of the embolization. And for some patients, we can also inject the embolic materials, just to use a double lemon balloon, just like this patient is with the AVM in the occipital lobe. And you can see here we choose a Sept balloon, which is the double lumen balloon. We after infiltrate the balloon, then some onyx were injected into the nidus of the AVM, and resulted in total obliteration of the AVM. And also dural catheter techniques is a new emerged techniques in their embolization. And you can this is a 21-year male patient presented with the hemorrhage, intravascular hemorrhage, and the DSA shows the AVM in the occipital lobe, and which was fed by the PCA and also by the ACA. And this is the fusion of the 3Ds, and you can see here there are 2 main feeders, and we use dural aplo catheters to select the feeding arteries, and onyx was injected into the nidus and resulted in total obliteration of the AVMs. And this is a recently published study published literature, which is shows the long-term efficacy and the safety of the dural micro technique, and which shows this technique will increase the totally obliteration rate for the transarterial embolization. And what is the safety and efficacy of the curative embolization? And you can see here in the recent published study, which has included over 2,000 patients, and in this case series, only transarterial embolization was used, and they got a complete exclusion of the AVM, about 22%, and with a very good outcome. So then, which patient should we choose to perform a curative embolization transarterially? So we must know which are the factors predicting their complete obliteration or incomplete obliteration. In 2008, Andrew has suggested that for the micro AVMs, which is smaller than 1 millimeter, supplied by normal-sized tortuous arterial feeders was at high risk for incomplete obliteration. And other authors has suggested that the factors associated with the incomplete obliteration were the lighter size of the for a larger AVM that is over 3 centimeter, and AVMs with multiple arterial feeders. And while the factors predictive of complete obliteration were smaller AVMs and a single arterial pedicles and a lower spasmatic rate. And also a lower spasmatic rate is suggested by the other authors. And incomplete obliteration predictors are multiple small feeders. It's also suggested by the other publications. So for the patients for transarterial curative embolization, the ideal candidates is the size of smaller than 3 centimeter and superficial and lung diffused with lung diffused niders. What's more, the original of the drainage vein should be easy to recognize. If there is a feeder of the diameter of the feeder is larger than 1 millimeter, it will be more easier to get totally obliteration. And some authors has produced some scores for predicting the result of transarterial curative embolization, such as the AVMs produced by the loopers, and also the Buffalo scores. For these scores, are grid systems. The number of the arterial pedicles and the diameter of the arterial pedicles are very important for these all these scoring systems. But even for very small and single feeding AVMs, there is challenges for transarterial embolization. So just like this patient, which is a 54-year-old male patient presenting with a hematoma of the occipital lobe. And you can see from the CTA, there is the AVM of the occipital lobe, and which has been approved by the DSA. You can see here there is a small AVM and also just a feeding by one single, maybe just one single artery, but the artery is very tortuous, and we use transarterial embolization for this patient, and a pressure cook technique was used, and Apollo and Marathon was used for the embolization. Apollo is for injection of the onyx, and Marathon is used for pack the coils and inject the glue. So you can see here we get the total obliteration of the AVM, and with the infiltration of the onyx into the drainage veins and the whole lighters. And we get the total obliteration of the AVM. But after the operation, the embolization, there was post-operative neurological deficit happened in this patient. He presented with a partial sensory aphasia and alexia, maybe caused by the occlusion of the perforators because of the extensive infiltration of the onyx. So and also for the other deep located lesions, just like this patient with their thalamic AVM, and only supplied by the perforators from the PCA. We cannot embolize this patient with transarterial embolization. So for these kind of patient, transvenous embolization should be used. And during the recent 10 or 15 years, many studies has been published to prove the safety of the transvenous approach embolization. Just like this patient, he is a 55-year-old male patient with a ruptured AVM, which has been ruptured twice. And after the first rupture, we embolize this patient transarterially, but he ruptured again even after radiosurgery. And after 3 years, their AVM re-ruptured again. So for this patient, we choose the transvenous embolization. And it is very important that we should recognize the junction of the drainage vein of the AVMs and of the normal drainage vein, deep drainage veins. So we recognize here we should not occlude the normal veins. So the embolic material should stop here. So we use the retrograde pressure cook techniques, and some coils was packed into their drainage vein, just distal to the junction of the normal vein, drainage vein. So after the injection of the onyx into the niders, the procedure resulted in total obliteration of the niders. And also for the basal ganglia area AVMs, even with multiple drainage veins, we can also safely embolize it with the transvenous approach. You can see here we use a microcatheter into the perforators of the nitrograde artery, and we also used a balloon in the arterial MCA to control the blood flow, and then microcatheter was navigated into the main drainage veins, and also retrograde pressure cook techniques was used, and onyx was infiltrated into the niders, and you can see the reflex into the feeding artery and the other drainage veins. So, and we got total obliteration of this AVM. And we also extended these techniques from the deep located AVM to the superficial AVMs, just like these publications suggest. Most mostly we used for the superficial eloquent area AVMs. And just like this patient, he is a young patient presented with epilepsy. And you can see here the AVM located in their cortical area of the for the BRCA area. And we do the water test before the fortunately, we want to partially embolize the AVM transarterially to control the blood flow. So we did the water test before the transarterial embolization when the patient was awake, and some particles was super selected for embolization because in these particles some propofol was injected and neurological deficit happened to the patient when he is awake. So this is the first session. Some particle was embolized transarterially, and this is the image after the first session. And you can see there is only one drainage veins. So in the second session, we do the transvenous embolization, and two microcatheters was navigate into the drainage vein and into the into just the beginning of the drainage veins. And there's some after the pressure cooker technique, onyx was injected into the niders, and the result immediate total obliteration for the AVM. And this is the follow-up image for 3 months later, and also shows the total obliteration. And also for the motor area AVM, we just do the one session embolization transvenously, and you can see here we also embolize the AVM totally, and this is the immediate result. And for some superficial AVMs, which is difficult for transartery embolization, we can also use the transvenous embolization. This is a cerebellar AVMs with multiple flow-related AVMs, aneurysms. Fortunately, this is a ruptured one, and fortunately, we transarterially embolized some part of the AVM and all the flow-related aneurysms in the first session. And in the second session, you can see here there is there is only small particles feeding the AVMs. So we cannot get a total obliteration through transarterial embolization. So we choose to embolize this patient with a transvenous approach. And you can see here, guiding catheter was navigated into the straight signers, and two microcatheters was navigated retrogradely from the drainage vein to the exact beginning of the drainage vein. And after the retrograde pressure cook techniques, the AVM was totally embolized. Just now, you can see we most of the patients we embolized with the AVM smaller than 3 centimeters. But how can we deal with the AVM larger than 3 centimeters? You can see here it's a young patient, male patient, and he was presented with a recurrent growth seizure for 1 year. And you can see there is a big AVM which fed by the branches of the MCA, lenticular straight arteries, and branches of the ACA, and even with the collateral arteries, and also the recurrent artery of the Huberner and the collateral arteries from the ACA, and drainage by this single drainage vein, which is the Curative veins. And so we decide to totally embolize this patient because this it cannot be resected by the open surgery, and the radial surgery maybe will result in a lower totally eradicated rate. So we choose to embolize this patient firstly with several sessions of transarterial embolization, and we decided to embolize the lesion with the transvenous embolization in the last session. So in the first session, you can see here some part of the AVM was embolized, and this is the embolization of the second session and the third session. And after the third session of the transarterial embolization, you can see there is only a small part of the AVM left here, and which was supplied by the lenticular straight arteries, which is very difficult for embolization transarterially, but it is just only drainage to this main drainage vein. So in the last session, which is the fourth session, and we tried to embolize it with the transvenous embolization. This is a immediately result after the embolization. You can see the AVM was Sept totally embolized with only very small remnant that was here, AVMs here. So we made the patient in anesthesia, in gross anesthesia for 3 days, and lowered the blood pressure. And 7 days after the embolization, we follow-up angiography was performed for this patient, and the lesion, there was no residual AVM left. And this is a follow-up image of the 8 months, and you can see here the AVM was totally obliterated. And how about the diffused AVMs in the diffused deep located AVMs? And this is a 16-year female patient. 4 years ago, she suffered from intraventricular hemorrhage, and we partially embolized the AVM, and gamma knife was suggested for her for 3 times, but the intraventricular hemorrhage happened twice again for her, just 4 months before the last admission for the patient. And you can see the DSA here, which shows there is a diffused deep located AVM, but which has been supplied by the anterior circulation and also by the posterior circulation. In the anterior circulation, multiple lenticular straight arteries feeding this part, and for the posterior circulation, there are also some very small perforators feeding this part of the AVM. So transarterial, it is not it is not a candidate for the surgical resection, and the radial surgery is not successful for her. So we try to embolize this patient. And if we try look the merged images for the AVM, you can see the AVM was divided into two parts, and one part is here, which has been supplied by the anterior circulation, and this part is supplied by the posterior circulation, and the drainage vein joined here together, so we can maybe we plan to stage the embolize their AVM. Firstly, we will choose to embolize this part, which has been supplied by the posterior circulation, and then this part, which is supplied by the anterior circulation. And so this is the first part, and you can see the drainage vein from this part were super selected, and pressure cooker technique was also used, and onyx was injected into the niders, and the infiltration is good. And then we do another plug into the main drainage, and also the drainage veins was super selected with a dural catheter, and onyx was injected into the niders, and you can see here the infiltration of the onyx. And you can see the totally obliteration of the AVM immediately after the operation. And this is a 3 days follow-up image after the embolization, which shows totally obliteration. And this is the 4 months follow-up after procedure. You can see the result is also stable. So is it safe for the transvenous embolization? And you can see here in the a recent published systemic review, it is for a high selected patient, it is the mortality rate and the neurological deficit is quite low. And also, you can see here that we can embolize some AVMs with curative embolization. So how about the first line strategy for curing the low-grade AVMs, both with the transarterial embolization or transvenous embolization? And you can see the published literature, the result is quite good. And you can see here, nearly 90% of the patient got their complete exclusion of the niders, and over 97% of the patient have a favorable outcome, and the neurological deficit most often transient is quite low, and the permanent neurological deficit is quite low. And so for the embolization of the AVMs with the intent to cure the newly temporary neurological deficit and procedure-related mortality is quite low. So if we look at the Aruba again, and they are quite lower than their stroke and death rate of their medical management arm. So maybe it's time for we to stick to their curative embolization for super selected AVMs. So just like the editorial of the neurosurgical focus that maybe if we want to get an easy conclusion, then that the randomized multiple center trials may be required. But the truth is that a perfect trial is neither feasible or realistic. So we need to conduct a well-executed registry for patient data for multiple center and to get the solid data to guide the selection of the best treatment for the AVMs. If we can get a summary, then if we want to do perform a curative embolization for AVM, we must period to their embolization, we must get a comprehensive analysis of the architecture of the AVM. And we will use some new materials and techniques should be used to embolize this. And which are the optimal candidates for curative embolization? That is, the size of the AVM should be smaller than 3 centimeters and with long diffused niders and easily recognized original of the drainage vein. And for the transarterial embolization, nowadays only only low-grade lesions should be chosen to perform the curative embolization. That is superficial and long eloquent niders. And if there is a dominant feeding artery with a diameter larger than 1 millimeter, then it will be better. And for the some higher grade AVMs, which lies in the eloquent or long eloquent areas, but drained by a single vein, and on feasibility for arterial embolization, they may be optimal candidates for the transvenous embolization. Thank you.
Thank you, Dr. Lee. So very wonderful talk, wonderful lectures about new trend of arterial embolization of AVM. So very nice results of the transvenous embolization. So congratulations. I have a few questions for you. And now you are using an Onyx for mostly all cases of AVM, or still now you can use an NBCA in some cases?
Yeah, yes, thank you for your question. In most of the cases, we use the Onyx, but we sometimes we use the NBCA. That is, in China, we only got the glue brand. Then with the very small niders to perform the curative embolization. But for the most of the small or middle-sized AVMs, we only use the Onyx for as the main embolic material. But for the patient with the staged embolization, we will use the glue brand to firstly to embolize some microfistulas or some part of the AVM, use the glue.
Such a high flow shunt, you use in a glue.
Yes.
Yes. Okay. And now in your strategy, I know you are both Professor Jiamin Liu. Well, I think. Yeah. I know he's a very aggressive man, and so you also challenge so very difficult AVMs, and so you show the one very big superficial AVM with transvenous embolization after some session of transarterial approach, and so in such a case, particularly in the transvenous embolization, already the Onyx cast is inside the AVM nidus, and it's difficult to the junction of the nidus to the drainers. How do you identify such an exact part of the nidus? Because the onyx will disturb the view.
Yeah, it's a it's very important for the embolization. Yeah, thank you for your question. Before the procedure, we will plan how can we embolize it, because if we just so that is why in the first 3 sessions, in the 3 sessions, we use the onyx to embolize the AVM, because the AVM is quite big. It is big, larger than 3 centimeter. So yeah, if we just embolize the particles, not part of the AVMs, then the AVM, the lighters is still very large for transvenous embolization. So we try to embolize some part of the AVMs or some part of the AVMs with very aggressively with the transarterial pressure cook techniques, and to ensure this part of the AVM is totally embolized. And we only left a small part of the AVM left for the transvenous. Yeah, we cannot see clearly. Is there any part of the AVM which has been supplied by the particles we previously embolized has left? But we do the rotations, the DSA and other techniques just to ensure there is no other particle, other parts left. But even after the embolization, there are still some part of the AVM left. So for this patient, we cannot get additional transarterial embolization. So we perform a gross anesthesia for this patient for more than 3 days. And after he wake up, we still lower the blood pressure, and after 7 days, we do the follow-up DSA to ensure every part of the AVMs was occluded. There is no residual nidus left. So it is very aggressive, but and we maybe we should get prepared for everything.
Okay. And the last question: when the AVM is remaining, even after the transvenous embolization, the second operation will be the surgery, extirpation, or radiosurgery. What is your strategy after the remnant nidus after the embolization? So do you go to the radiosurgery or surgical extirpation? Which is more?
Oh, yeah. We will. Maybe there are. Firstly, we will try to perform a transarterial embolization, additional transarterial embolization to get a solid result. And when the transarterial embolization is impossible, and we will then we will get perform a gross anesthesia or just a deep sensation for the patient to lower their blood pressure, and for more than 72 hours, that is for more than 3 days, and then 1 week DSA follow-up will be performed, and if hemorrhage happen because of the remnant AVM, and open surgery will be conducted to him.
Do you have an experience of such a post embolized hemorrhage?
Yeah. Yes.
Okay.
Okay.
But, thank you.
Only 2 patients.
Yeah. Only 2 patients. Okay. So, Raja, we will open the discussion or to the
yes,
comments.
Sure. We can invite comments. Professor Shubin is here, one of the experts. Yes, Professor Shubin. Any comments?
There's a question from the audience. I wonder what's the advantage of double microcatheter, and how about if we do the embolization of the feeders 1 by 1?
Oh, okay. It's a good question. Then, by using the dual catheter technique, and we can understand the angio architecture of the AVM better, because with the 2 catheters in their feeders, if we injected contrast 1 by 1, and you can understand how the niders of the fed by different pedicles join together, and how the branches of the drainage veins join together. So it will be better for us to understand the architecture of the AVM. This is the first advantage. And the second is it will be more efficient for we to inject the embolic materials, because when you are inject the onyx with the 1 catheter, sometimes will be need to wait for the onyx infiltrate into the niders. If the onyx reflex, even with the pressure cook technique, some reflex will happen. You must wait. But when you are using the dual catheter technique, you will when some reflex or a long-wanted air infiltration happen, you can inject in the other particle. So it will be more efficient.
Another question from Hashad. What's the rate of the rupture after AVM complete embolization, and if it does, then after how long?
Oh, sorry.
You can
for both transarterial or
after the AVM complete embolization. Yeah, what's the rate of the rupture after the embolization?
Oh, in our experience, maybe about more smaller than 10, maybe 6 to 9% of the rupture rate after the embolization. Maybe a little higher in the transvenous approach.
Okay, thank you. That's very nice presentation. Thank you, Professor Li Qiang.
Thank you.
Thank you very much, Professor Li Qiang and Professor Shigeru Miyachi. That was a wonderful feast of knowledge from both the legends, and thank you for sharing your experience with us. Because of the lack of time, we can move on to the second session now. So I'll hand this over to our second chair, Professor Jayanand Sudhir.
Thank you, Raja. It's been an honor to be on this meeting as well as to chair a session. And also a pleasure to introduce the next speaker, Dr. Adi Ahmed Spahij from Sarajevo. and he's a young neurosurgeon. And by his profile, we have seen that he has traveled the world across continents, gained a lot of training in both skull base as well as cerebrovascular techniques. Today, he's going to share his experience of vascular cases.
Thank you, Professor John Sudhir, for a nice introduction. It's a great honor to be a part of ACNS webinar in front of such outstanding professors, masters, and it's my great pleasure. Just to disclose, I'm not a professor. I have the master degree in vascular neurosurgery, and I'm working currently in my PhD thesis in vascular surgery to become, I'm a PhD candidate. I work in a neurosurgical department in Sarajevo, which is the capital of Bosnia and Herzegovina. This is a Balkan Peninsula, and the Sarajevo is the capital city. I'm trained for 6 years, and this is the place where I'm currently working under reconstruction. This is the clinical center of University in Sarajevo, the largest hospital in our small country. And here is Department of Neurosurgery on the second floor. Those are the people who I'm working with. We have a team of chairmen, 4 consultants, 2 senior and 2 junior consultants, and 4 young neurosurgeons, as well as 4 residents. So I believe that the ratio between the young and the consultant, as well as the residents, is great for the developing of young neurosurgeons in our country. Here is Professor Omer Hodzic, who is our consultant neurosurgeon, president of Neurosurgical Society of Bosnia and Herzegovina, as well as Professor Eldin Burazerovic. Those 2 consultants are dealing with cerebrovascular pathology, and under their supervision, I performed my development and the progress. So how did it begin? I started my vascular experience during residency, and then I completed skull base and cerebrovascular fellowship, as well as some of cadaveric courses. Here is a Memphis, Tennessee animal lab for the practicing of the bypass surgery. This is from Al-Mefti's skull base lab in St. Louis, USA, followed by the cerebrovascular and skull base fellowship in Madison, Wisconsin, United States, under the mentorship of Professor Mustafa Bashkaya. Then after I've completed a minimal invasive and endoscopic fellowship in Weill Cornell, New York, under the mentorship of Professor Theodore Schwartz. This is a very nice lab for the cadaver practicing. They have the microscope, endoscope, drills, etc., what you need for your practice. And finally, I've completed cerebrovascular clinical and research fellowship under the mentorship of Professor Yoko Kato. This is from Fujita Health University. This is a image with the Professor Takizawa after STA-MCA bypass surgery. And I give my special gratitude to Professor Yoko Kato, who gave me opportunity to be part of their team and to be taught by our great leader, one of the leaders in cerebrovascular surgery. So since we are a small population, these are my personal results for vascular cases. I work as 3 years as an independent neurosurgeon. So I've completed 61 vascular cases, which is almost 20% of my general work, with a complication rate in terms of the surgically related complications of 3. So I had 1 wound dehiscence, which improved in conservative treatment, 1 revision surgery for wound dehiscence, 1 revision surgery for cavernoma, and by now I didn't have any surgical site infection. So let's review some of my cases. For all of my patients, I have a permission to publish when I take a video. So this is a case of lateral ventricle cavernoma, ruptured cavernoma, as well as partially in the thalamus. This is a young male patient with university degree. Here is the positioning of the patient and the linear horizontal skin incision, which is used. And by the neuronavigation system, we mark the sagittal, superior sagittal suture to perform the sagittal craniotomy, 2/3 on one side and 1/3 on the other. And here is the how large craniotomy we can get With this approach, by the usage of the falx as a contralateral retractor and the gravity by the ipsilateral retractor, we can perform surgery and resect the cavernoma. And here comes the postoperative MRI. There are no signs of residual cavernoma. The vein is spared. Here is the cavernoma. This is the patient after surgery, fully neurologically intact. And I can proceed with the other case too. This is the case of cavernoma plus ICA PCOM aneurysm. So this cavernoma I've operated twice. First time with the transsulcal approach, and then I had the residual cavernoma since the navigation system didn't work properly. But anyway, we completed the next surgery with the same incision, linear skin incision, with the same approach, and through the Transsylvian approach, we have clipped this PCOM aneurysm in the same act, and the patient went well after surgery. This is the example of the right parietal brain AVM in a patient who had a previous spinal fusion surgery. So the postoperative CT and CT angio revealed no signs of residual AVM. The patient went well, and here this is the microsurgical large exposure of the right parietal region. Here comes the case of 2 days old newborn with a ruptured AVM. In this patient didn't have any trauma related to the birth. So the patient presented in a comatose, deeply comatose state with GCS 4 to 5, with especially paresis of the right leg, intubated. So we performed this emergent surgery. And here comes the postoperative CT, MRI scan with this big perencephalic cyst, but the patient went well. In a newborn, I believe that we could have better results in this deep comatose state. The patient went well. The right side have improved 6 months after surgery, so we are very, very satisfied with this result in this baby. This is the case of spinal fistula, dural AV fistula on TH8, TH9 level. The patient had progressive neurological deficit in terms of progressive weakness and paraplegia at the end. So here is an intraoperative exposure of the fistula, which we closed. And after surgery, this is 2 months after surgery, patient improved very well with the neurological state. Those are some of my aneurysm patients. Most of them referred as SH cases, mostly ACOM and MCA aneurysms. Also, there are some of ICA PCOM aneurysms. This is the anteriorly projecting aneurysm, inferiorly projecting and superiorly projecting ACOM. Here comes the MCA aneurysm with the intracerebral hematoma, which will I show later the example. And of course, there are some unruptured cases of the MCA aneurysms. This is the presenting case of the ruptured MCA with the intracerebral hematoma, and with the Transsylvian route, we exposed the aneurysm. The vessels are quite atherosclerotic. So the clip may be placed on the neck of an aneurysm before we go for further exposure. It's very important for a young surgeon that he is under supervision of experienced consultant neurosurgeon in these beginner phases because of the safety of the patient. With this clip, here, when we expose the rest of an aneurysm, little vein has been cached behind the aneurysm, so we will pull the clip back to release this vein. And here is the M1, as well as the residual part of an aneurysm, which is closed then by the fenestrated clip to prevent further growth of the residual part of an aneurysm. So here comes our final result. I use a fluorescein as a contrast to check for the patency of the superior as well as for the inferior trunk. And here we have the final result, which will on the end be followed by the extraction of the residual hematoma in the brain. This is other case. It was challenging case for me as a beginner in vascular surgery. This is a young female mother of 3 with a large MCA bifurcation aneurysm. With a standard microsurgical approach, we open the dura under the microscope, and here comes the cilium fissure dissection. With the combination of the blunt and sharp dissection, we expose the M3 branches, which are then followed in a retrograde fashion towards the deep sylvian fissure to expose the M2 branch. And then we go in retrograde fashion, in retrograde direction to expose the bifurcation of an MCA. So in this part of surgery, we have exposed the M1, the superior trunk, the inferior trunk, and the base of an aneurysm. This is a broad neck, very thin walled aneurysm. We can even see how the blood goes through the walls. So after we prepare the neck for the clipping, we have attempted to first apply a pilot clip on the neck of an aneurysm, which sometimes serves as a final clip. But in this case, because it was a broad neck, there was a kinking of the superior and inferior trunk as well. So we haven't been satisfied with this result, and we proceed our dissection towards the exposure, the aneurysm from the frontal lobe. And here is the aneurysm, how it looks like before the second attempt of the clipping. However, we positioned this clip, it couldn't fit perfectly for that we wouldn't be afraid for a possible ischemia. So we deflate an aneurysm, and then maybe this position was fine because there is no kinking when the clips are released, but because of the posterior part of an aneurysm, we decided to clip with a curved clip, and residual part of an aneurysm is clipped by the mini clip here in a 90 degrees fashion, and one more clip will be applied to prevent further growth of an aneurysm. In this case, this is a young lady. Now we are satisfied with the enhancement, contrast enhancement of the fluorescein, and the patient went well. After the dura is closed, this is the postoperative CT angio with no signs of residual aneurysm. This is the patient after surgery, fully independent. This is the also other case of SH in a young female patient who had also some ischemia here. If she had a COVID just prior to the aneurysm rupture. So here is the 3D CT angios with the ICA-PCOM aneurysm as well as the anterior choroidal artery aneurysm. So in this case, we performed the right pterygium craniotomy for the clipping of both aneurysms. So here is an opening of the dura. There is a SH with the angry brain and some of the edema. I will skip part of the sylvian fissure dissection just to not take too much time. This is a proximal sylvian fissure dissection. And now we approach towards the ipsilateral ICA, where we can see blood around ICA and some arachnoidal adhesions, which are released from the ICA. The dome of an aneurysm, of the PCOM aneurysm, is projecting towards the inferomedial side. Here comes the dome. And now, after we dissect the dome away, we are looking for the little perforators and the PCOM, which is on the lateral side of the ICA, as we can see here. in this blood. This is a 3 days old hemorrhage. So after we release the PCOM from the dome of an aneurysm and expose distally the anterior choroidal, which is here, we use the clips. Sometimes we don't have the best fitting clips, so here is a very long curved clip to close an aneurysm. And here comes the anterior choroidal with this small aneurysm, which is exposed here. And this is the clip placement, one straight clip, usually with the change of the direction of the hand, could close an aneurysm. So here is a purely microscopic view of the PCOM and the anterior choroidal and the perforators, and here comes the contrast enhancement image of the distal patency. Here is the postoperative CTA. Patient had a severe form of the vasospasm, and this is the patient 10 days after surgery before we extract the stitches out, and the patient went well. This is a type of the mirror MCA aneurysm. On the right side, we have a larger aneurysm, which is 5.3, and on the left side, we have 4.8. Also, the patient had this tumor, which we resected, and the tumor was PhD revealed intraosseal meningioma. So firstly, we resected the tumor and then performed the pterional craniotomy for the rest of the flap, and clipped both aneurysms through the ipsilateral right side approach. This is the postoperative CT angio, how it looks like. There are 3 clips, and here is one fenestrated clip which closed this aneurysm. And this is the patient after surgery, neurologically intact, with the one side approach where we skipped other approach for the mirror MCA aneurysm. There is some atrophy of the muscle. This is 4 to 5 months after surgery. There is some atrophy of the temporal muscle, but the patient is well. Here I will just show you next similar case. This is the left side ICA fusiform aneurysm with the contralateral MCA projecting inferiorly and anteriorly. So this patient presented with the SAH, WFNS score 4. We decided to go for a surgery from the left side to close an aneurysm, and in this case we used the endoscopic assistant clipping. This is how it looks like with the endoscope. So purely by the microscope you cannot actually see well the aneurysm on the other side. By endoscope assistance, this is the Kinevo arm of the Kivo arm of the Kinevo microscope. You have a better visualization and illumination, and you can achieve more insight in the configuration of an aneurysm. So this is the microsurgical dissection, and now we will approach to the endoscopic assisted dissection of the vessels. So this is how it looks like under endoscope assistance. And what is most important in these deep-seated corridors, that you have a real insight for possible perforators. As it looks like here, those are some perforators which are adherent to the dome of an aneurysm. So purely by the microscope, they could be very hard to see because they are on the lateral border of an aneurysm. So by this exposure, this is the endoscopic assisted clipping of the contralateral MCA, and this is how it looks like at the end. If we don't use purely microscope, probably those clip would catch or kink some of those tiny perforators. So in this case, we can, under the endoscopic control, we can move the clip towards the base of the neck to close the clip safely. Of course, that you need 2 surgeons, your consultant and yourself, to do this surgery. And this is how it looks like after we extracted the after we placed the clip, we were satisfied with the position of the clip and at the end of the surgery. So here is the postoperative CTA. There are the clips on the ICA, and here is the clip on the MCA. This is a superior, this here tiny little inferior trunk, as same as in the preoperative CT NGOD. We didn't have any ischemia after this case. So let me just, my lecture is short. Let me conclude. This is a message, of course, for younger neurosurgeon. To understand complex vascular anatomical relations in the skull base, there is no change for mastering of the neuroanatomy as well as for the cadaver courses. To understand the perspective of other and to explore different options, multiple international observership fellowships are mandatory. Young neurosurgeon interested in cerebrovascular surgery must be well prepared and trained under experienced consultant supervision. Advice and assistance may be of utmost importance in the process of continuous progress. And if first and second steps are followed, and then we can sure conclude that Bosnia and Herzegovina provides a chance in a rapid professional development of the young neurosurgeon with positive results and low rate of complication. Thank you from Sarajevo.
Thank you, Dr. Adi, for a wonderful presentation. I think Dr. Adi's presentation has put into the limelight the need for focused training as well as dedicated cadaver training, and also the need to visit multiple centers so that you get the best practice guidelines from each center and inculcate the best practice scenarios, and you come back to your home station and practice them on the patients. But a significant emphasis should still continue on laboratory practice and cadaver practice, because that is the essence before the essence that has to be inculcated among young neurosurgeons before venturing into real patients. Very good work, Dr. Adi.
Thank you, Professor. Thank you. It was my great honor to have a chance to talk today.
Since there are no questions in the chat box, maybe I can ask some of the panel members. Dr. Zubin, would you like to make some comments?
Hello, Adi. I think this is a very good opening for your career. Yeah, very nice. Thank you.
Thank you, Professor Shubin. Thank you so much. And also, I want to use my opportunity to express my great gratitude. Here I see Professor Ibrahim Omerhodzic, who is our president of our Neurosurgical Society, but he's also my consultant neurosurgeon, one of two, Dr. Eldin and Dr. Ibrahim. Without them, without their support and assistance in these cases, I believe I wouldn't have success. And thank you, Ibrahim.
Dr. Adi, you have attended a lot of fellowships and training programs abroad. But do you have any practice at home at your University of Sarajevo? Where do you have you set up any laboratory for practice?
We don't have a lab actually here in Southeast Europe. There is no real cadaver lab and the model lab. So that's why most of young neurosurgeons from this region goes abroad to EU countries as well as United States. Some of them were in China too and Japan. So we have to go abroad for this type of training. But for the neurosurgical assistance for the vascular cases, we are lucky that we have very experienced vascular neurosurgeons, and that's actually our base. We just have to add some more of our training to see, as I mentioned, perspective of other in other high volume centers.
Yeah, I would also encourage you to set up a laboratory for vascular training, because it's easy to set up a lab for vascular training, especially with microvascular instruments, as well as the animal specimens may be easy to get. So it's easy to set up a training station for vascular anastomosis and practice, and that helps a lot in career growth, because the speed and efficiency of your procedure during surgery determines a lot in the outcome of such patients in vascular neurosurgery. So I think most centers should develop their own vascular training laboratories. It may be difficult to set up cadaver laboratories, but vascular training stations are easy to develop.
Thank you for advice, and we are working on that to establish a lab in our university center. So I believe we will make it soon. We are a small population country, 3.5 million, which is that's our population. So, but it's going to be a first center probably that has a lab for practicing of young neurosurgeons who are interested in vascular surgery.
Right, and a good set of cases that you have shown, and the attitude and the poise of your operating skills were well, excellent, and very well demonstrated.
Thank you, Professor. Thank you.
Over to Dr. Raja, if there are no comments from.
Thank you for these wonderful comments and wonderful case presentations, Adi. It was great to see you blossom under the mentorship of great neurosurgeons like Ibrahim and others. Thank you very much for showing those cases, and extremely grateful to Dr. Jayanand for chairing this session. He is the most apt chair. He went to Teshinkai, came back here, and started so many bypass cases. We are extremely fortunate to have him here. Professor Shubin, any concluding remarks from you?
Yeah, tonight we have around 500 audience in the WeChat channel. So congratulations for the both speakers. Thank you again.
Well, thank you very much. So with that, I would like to close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers of today, Professor Lee Kiang and Dr. Adi Ahmed Spaij, and the chairs, Professor Shigeru Miyachi and Professor Jayanand Sudhir, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and also to my co-host Dr. Liu Boon Singh, who is from Malaysia and joined us today. A special thanks to all the elite panelists who joined us today. So until we all meet on next Wednesday, it is bye-bye from all of us. Thank you very much for joining.